I'd like to call the meeting to order. Good. My name is Dan Ulliott. I'm the chair of the panel, and to my right is Dr. Paul Heidenreich, who is our vice chair. I want to welcome you all to this meeting, which is the integrating of behavioral health with primary care. I'd just like to say a word about our panel. We have a panelist sitting up here in front of you. This is a diverse group, a very distinguished group of medical and surgical specialists, primary care physicians, methodologists, ethicists, patient advocates. And I guess our collective strength is that we are generalists, we are disinterested, we don't come with any particular agenda except to look at the evidence as honestly and as critically as we can and hope that we can make recommendations that will become useful. I would like to now introduce Karen Shore. Dr. Shore is the program director at ICER. She obtained her PhD in Health Services and Policy Analysis at UC Berkeley, and she is instrumental in setting up our program, and I'd like to turn it over to Karen. Karen?
Great. Thank you very much, Dan, and welcome everyone who's here with us. We're also doing a live webcast for those who couldn't join us in person, so welcome to those folks as well. This is our first meeting of 2015. We have 3 public meetings a year, and this is our first, as Dan said, looking at integrating behavioral health into primary care. Just a moment, so thank you all for joining us, but also wanted to thank our funders, the Blue Shield of California Foundation and the California Healthcare Foundation. For those of you who are here in the room, please put your phones on vibrate, and if you need to use the restroom, it's down the hall past the entry on the right, so feel free to head there as you need. Our agenda for today, we're going to spend the morning. I'm actually going to give an overview, some background and context for this meeting, and then turn it over to Dr. Jeff Tice and Dr. Dan Ohlendorf, who will do some evidence and economic modeling presentations, and then we'll wrap up the morning with some public comments. After a lunch break, which will be out here in the same area as breakfast was provided, there will be a discussion. We'll bring up our policy roundtable for the afternoon. They'll sit up here, and the panel will review a set of voting questions, which are everyone should have, and and consult with the policy roundtable as they're thinking about those voting questions. And then most of the afternoon will be spent with the policy roundtable discussion, a couple hours where we'll review what's been discussed in the morning and talk about needed changes in practice and policy going forward. And then we'll wrap up with reflections from the panel, asking each person to share their thoughts on kind of what they've heard through the day and where to go next. And then we'll wrap up around 4 o'clock. For those of the people not in the room, if you're interested, you can download the meeting materials at the website that is shown here on the screen. It's tinyurl.com/CTAF-BHI. So hopefully that's a good overview. Back to you, Dan.
Okay, just a word about the California Technology Assessment Forum, CTAF, a little explanation of our culture. Let me read the mission statement, if I may. The California Technology Assessment Forum, CTAF, is a core program of the Institute for Clinical and Economic Review, reviews rigorous ICER-produced evidence reports, and provides a public venue in which the evidence on the effectiveness and value of healthcare services can be discussed with the input of all stakeholders. CTAF seeks to help patients, clinicians, insurers, and policymakers interpret and use evidence to improve the quality and value of healthcare. Our vision, through its work, CTAF aims to help create a future in which collaborative efforts to move evidence into action provide the foundation for a more effective, efficient, and just healthcare system. As far as conflict of interest, we have polled the panel, And to my knowledge, we have no panelist who has a financial conflict of interest. And so when we have public comment or any of our expert panelists, we would ask them to disclose any conflicts of interest for this topic before they make their presentations. So Karen, back to you.
Okay, great. Thank you, Dan. And you provided a little bit of a CTAF overview. And as Dan said, CTAF is a core program of the Institute for Clinical and Economic Review, or ICER, which is an independent nonprofit based in Boston. We review the scientific evidence on clinical effectiveness and the cost implications of different drugs, devices, and delivery system innovations. And Dan's already covered our goals, but I want to mention just a couple things about how CTAF is a little bit different from some other technology assessment organizations. And one, as Dan mentioned, the panel here that you see is the public deliberation and voting by the CTAF panel, independent members of this group. And then in the afternoon, as I mentioned, we'll have a policy roundtable discussion where we bring in subject matter experts to talk about the implications of and applying the evidence to practice and policy. And as I mentioned earlier, we're funded by the Blue Shield of California Foundation and the California Healthcare Foundation. So I have no conflicts of interest. I wanted to talk a little bit, just a background, for those of you who may not know this, that this topic is really CTAF's first foray into a topic that's not a drug, device, or procedure. So it's a delivery system innovation or delivery system change. And it turns out that this is a very complex topic with a tremendous amount of information and in a field that is certainly evolving and has been for a couple decades. It also turns out this is quite a complex topic and not a lot of agreement about terminology. So we thought we'd start a little bit with just some definitions of what we're, for us, for our conversation today, for this meeting, and also in our report, what we mean by behavioral health integration and behavioral health. So behavioral health integration for us is primary care that addresses both physical health and behavioral health needs in primary care settings through systematic coordination and collaboration among healthcare providers. So again, not everyone uses this definition. For some people, behavioral health integration also refers to, for example, the provision of primary care services in specialty behavioral health settings. But again, not us for this purpose of this report or this meeting. And then excuse me, so behavioral health is also broadly defined. Pardon me, fighting a cold. I'm almost better. It's been my third week, right? So, so broadly defined by the Agency for Healthcare Research and Quality, and this is in the voting question handout, to include mental health and substance use conditions, health behaviors, life stressors, and stress-related physical symptoms, among others. And in our report, we are really focused on programs to address mental health and or substance use disorders that are frequently diagnosed and managed in primary care settings. So we're not focused on those other things in the ARC definition or on serious mental illness known as SMI, addiction, or serious substance abuse. And as the field is evolving, however, most of the evidence on clinical effectiveness and cost impact have generally been limited to the mental health conditions, but the field is indeed evolving to include substance use disorder and other conditions. And Dr. Tice will talk more about this, but the clinical effectiveness review really looked at primarily anxiety and depression in primary care. And during the policy roundtable discussion this afternoon, we'll have a chance to talk about what's available in the published literature versus what's actually being done in practice. So again, a little bit new for us at CTAF, having a chance to provide some context. This is chapter 2 of our draft report, but a little bit of background as we're thinking about this issue. So a lot of patients would have both mental health conditions and medical conditions. So again, the data is about mental health primarily, but about 30% of the adult population with a medical condition, one or more, also has a mental disorder, and about 70% with mental disorders have a medical condition. There's been a lot of fragmentation. That's a key word I think that we'll talk about a lot today, with a history of separate treatment and financing of physical health, mental health, and substance use disorder, separate funding streams. Efforts have really been underway, though, to integrate care with a goal of what's now called the triple aim of better outcomes, better patient care experience, and reduced costs. So there's a lot of support in the field for from both private and public sector organizations to research and implement and evaluate these integration efforts. So for our review, we had 4 components looking at the comparative clinical effectiveness and value of behavioral health integration, or BHI, looking at those components potentially associated with successful integration, looking at budget impact, and then finally identifying some barriers and potential solutions related to BHI for California. Again, back to the fragmentation issue, it seems that fragmented care has kind of become usual care, and in part due to various regulatory requirements and different agencies working on this, different funding streams. In California, there have been 2 what are called realignment efforts over the last couple decades that have shifted responsibility for mental health to the counties. And for individuals who do not have private insurance but who have a disabling mental health condition, typically get their care through county systems. And you can see either provided by the county directly or through a federally qualified health center or some other provider. At the state level, though, there's been some bringing together of the different entities working on this topic. So in the last couple of years, previously separate agencies on mental health and addiction, alcohol and drug agencies were incorporated into the Department of Healthcare Services. Medicaid billing, always a interesting topic. So CTAF has a sister program in New England called CPAC, and they're also going to be reviewing BHI at their May 1st meeting. And so one of the things as we're working on this report was to see across the country so many different rules and requirements for Medicaid programs in terms of billing for behavioral health integration services. So in California, a few things to highlight. Our Medi-Cal program limits the types of providers who can bill for specific procedures and diagnoses, and you can see the list here. Typically does not reimburse for care coordination services that are often important for BHI, and typically doesn't reimburse FQHCs for both physical and behavioral health services that are provided on the same day. And several other states do allow that. So information sharing is particularly important for BHI, but there are restrictions on the disclosure and use of patient information, and this is governed by the HIPAA rules. And then for behavioral health, a couple things that for substance use disorder in particular, there's more treatment for that, more restrictions about sharing of data or criteria related to that, and also that even though there's been a lot of adoption in primary care settings of electronic health records or EHRs recently, there's less of that in the behavioral health providers. And in California, in many cases, but not all, there's a requirement that express written permission from patients is obtained before information can be shared across providers. There's also a history of carve-outs for behavioral health care. Nationally and here in California, organizations called Managed Behavioral Health Organizations, or MBHOs, have accepted responsibility for providing behavioral health services from public and private health plans, and this has contributed to fragmented care as well. Issues that were identified related to this were misaligned payment incentives between primary care or between physical health and behavioral health. Many of the MBHOs pay their providers on a fee-for-service basis. There's also limited information exchange between behavioral health and physical health providers. And starting in January of 2014, Medi-Cal managed care benefits in terms of mental health, patients with serious functional impairment continue to be served through the county mental health plans, but there was a significant expansion for patients with low to moderate functional impairment who now can receive services through their Medi-Cal managed care plan that were not covered before. And then finally, just a lot of opportunities related to the Affordable Care Act and other payment and delivery initiatives underway, accountable care organizations, patient-centered medical homes, and others that present some opportunities to facilitate behavioral health integration. Under the ACA in particular, Medicaid health homes under Section 2703, I think California is looking into that. Some Medicaid expansion to groups of enrollees who were not previously eligible for coverage. and additional funding for federally qualified health centers, the FQHCs. And then also some opportunities around telemedicine. So this has been described as a potential way to improve access and address provider shortages or maldistribution of providers. They're not in the parts of the state where they're necessarily most needed. So that's just a little bit of background and overview, stage setting, and some things to be thinking about as we hear the next presentations. So that's it for me for now, and I'm going to introduce Dr. Jeff Tice, who will be doing a review of the evidence on clinical effectiveness.
Thanks, Karen. It's great to be here. So I'm going to launch right in. I have no conflicts of interest on this topic. This is a huge topic. There have been at least, there are actually more than 25 systematic reviews and a large number of, I'm sorry, I'm getting some signal about, oh, it's not me. Okay, never mind. A large number of systematic reviews by high-quality organizations like AHRQ and the Cochrane Collaboration. And given the large number of studies, we elected to primarily use the systematic review results because they were high-quality systematic reviews. We did update the systematic review, the most recent one by the Cochrane Collaboration. The full review was published in 2012, and they did an updated publication looking specifically at depression, which was published in 2014. So we updated the review ourselves and found additional publications from the same trials, but no additional trials at this point. And we use the quality rating that ICER uses, which is adapted from ARC. And I should say, in most of the, well, in all the studies, patients were not blinded to what was going on. One of our panelists highlighted that that's a particular issue in studies where the outcomes are self-reported, so subjective outcomes. Those are the studies that are most subject to a placebo effect, so improvements in outcomes just from being studied and asked and knowing you're getting something new. Self-reported pain, depression, things like that are outcomes that are often very susceptible to the placebo effect, and so it's a challenge in this literature. I think Karen alluded to this earlier. We tried to be fairly broad and included studies of men and women of any age, but at least half of them had to have anxiety or depression because we were focused primarily on common disease, mental health disorders in the primary care clinic. We also included studies of patients with chronic medical conditions who also had depression. Diabetes was the most commonly studied condition, but hypertension was looked at, heart disease, asthma, COPD, among others. As I alluded to, there's a large literature, at least 94 randomized trials with over 25,000 patients, and most were in primary care, and we focused on this literature. Some were in neurology clinics, some were in cardiology clinics, some evaluated patients with acute coronary disease in the hospital and followed them out, usually through the cardiology clinics. Most were done in the United States. The literature was very, very heavily in the United States early on, and other healthcare systems have started to adopt similar approaches. And an important nuance, which wasn't highlighted in the initial written report, but we want to highlight here, is that essentially 100% of these studies use some form of the collaborative care model and other forms of integration, true co-location of a psychologist or a psychiatrist in the clinic with primary care physicians. That has not been studied in careful randomized trials, though these are being rolled out in demonstration projects. There are also no studies that really carefully looked at the collaborative development of a treatment plan by the psychologist or psychiatrist with the primary care physician and moving forward with that treatment plan. They all used what we call the collaborative care model, which is essentially, I mean, there are many different flavors, but core components are a care manager in the clinic who helps to often screen for a mental health disorder, follow up on with regular checks to see how the patient is responding, coordinates with the primary care physician and the mental health specialist, and if the patient is not responding as appropriate, works to change the treatment plan and implement it. So it's sort of the glue and the liaison between the patient, the mental health professional, and the primary care provider. A number of different systems have been studied. This has most commonly been studied in integrated health maintenance organizations like Kaiser and Group Health. The VA is essentially a similar integrated system, and almost 1 in 5 of the studies were performed in the VA. So about half of the studies were in more integrated systems. About 47% were in non-integrated systems, and some of the studies included multiple systems in their study design. And I'll give a couple of examples of that. About a third of the studies just focused on medication management, making sure the prescription was filled, checking in for side effects, augmenting or increasing therapy at the appropriate time. About 10%, a little over 10%, focused just on psychotherapy, and about half included both. The outcomes for the primary mental health disorders, depression and anxiety, there are a number of different ones. The most common one is a change in some score. There's not a lab test for depression or anxiety. You need to ask patients questions, and based on those responses, there are a number of different instruments that are used for both depression and anxiety. You get some score, and we're looking at a change in the score as one of the primary outcomes, a reduction in high anxiety or high level of symptoms associated with depression. The general definition for a response to therapy is a 50% reduction in the score across a number of different instruments. And remission, usually there's some threshold below which you would say someone does not have an underlying depression or anxiety score. So a remission means moving the patients down below that threshold. And adherence to medical therapy was also an intermediate outcome that was, or a process of care outcome that was often studied in these. When trying to put these together, the most common outcome reported in meta-analyses is something called the standardized mean difference, which I understand is not intuitive for anyone in this room, including myself. And I put the definition up here, but essentially it looks at the change compared to the variability in the measure, the standard deviation. A movement of one unit of standard deviation would be a huge change in outcomes. There are some guidelines for what's small, moderate, and large. I put them here, but it will be. I think this is an important thing to discuss today. I will give some examples from individual studies to hopefully give you a little bit more of a flavor of the true magnitude of the impact of the various programs. So with that, I will move specifically to depression, and sort of the most cited study in this field is the IMPACT trial. It's unique because of the large number of patients. 1,800 patients were randomized in this. And more importantly, the number of clinics. There were 18 clinics from 5 different states listed here. HMOs were included, fee-for-service clinics that operated on a fee-for-service program, public health clinics, a wide variety of clinics were represented. So this is a very generalizable result. They did include patients who were identified through systematic screening. So every patient coming into the clinic had a screening questionnaire for depression, and if they tested positive, follow-up, a more detailed evaluation was performed to try and systematically identify patients with depression, and they also included patients who were identified by the primary care physicians in the clinic. There was a care manager who provided education, again, who was the glue. They provided medication management, followed up with patients, and were available to perform brief psychotherapy, something called problem-solving therapy, a form of cognitive behavioral therapy was the core of this, and this has been adapted throughout. So not intensive psychotherapy, fairly limited. And here are the primary results at 1 year. This is a study actually that had offered results at 2 years and followed patients up for many, many years in the study. But just for an example, their continuous outcome measure, their measure of depression was a symptom checklist with 20 items on it, so the SCL-20. And you can see that the score went down from 1.7 to 1.0 in the integrated care or collaborative care model, those who got the active intervention, and decreased from 1.7 to 1.4. So a little hard to get a sense of what that means. It was highly statistically significant. I think the response and remission numbers are more meaningful for those of us in the room. The response rate in the usual care was about 20%. It went up to 45% with the IMPACT program. The proportion of patients who remitted, so were cured, had their depression resolved at 1 year, was 8% in the usual care arm and 25% in the active treatment arm. So the vast majority of patients still suffered from depression, but there was a big impact of the care management program. Medication use, antidepressant use was higher, and patient satisfaction with their depression care was higher. So I think this is one of the more positive trials. When you look at 79 studies, lump them all together, that standardized mean difference is about 0.3, 0.28, highly statistically significant. This is a very tight confidence interval. And when you look at the percentage of patients, the absolute improvement in response rate, it's about 18% overall across these studies. Remember, in this prior study, it was closer, it was 26%, so a larger increase in the IMPACT trial, but about 18% overall, and the median absolute increase in remission was about 17%, which is very similar to the IMPACT study. Now I'm bouncing around. All right. So, overall, I think there's no question that there's benefit to the collaborative care model interventions for reduction in depression. The question is the magnitude of the net benefit, whether this is considered a small. By the SMD metric, it would be considered small, but I think many people would consider an absolute increase of 15 to 20% in remission and response to be a moderate to substantial improvement in outcomes, and that would be an important thing for us to discuss today. So our initial assessment was that this was a high certainty of at least a small net benefit, if not a moderate to substantial benefit. For anxiety, the literature is smaller. There's one classic study, the CALM study, which was modeled on the IMPACT study, so a similar type of intervention. 17 clinics, about 1,000 patients. In this case, anxiety was identified by the primary care providers. Again, you had care managers, but these were not experts in behavioral health. They received, again, they delivered education to the patients about anxiety disorders, provided care management, medication management, and offered similar brief psychotherapy. Their outcome score is, it was a 12-item questionnaire, And you see that with the intervention, the score went down from 16 to 8, so was cut in half on average. For usual care, it dropped from 16 to 11, so a smaller decrease, and the difference between the two was highly statistically significant. The response rates were 45% in the usual care, and I should say that's another important thing to think about with behavioral health outcomes. Most behavioral health illnesses, depression and anxiety, wax and wane. So patients get better on their own. So that's also an important thing when thinking about this, that patients do get better. So sometimes it's hard to show an increase over background. So in this case, 45% of patients in usual care responded, 64% with the integrated program. Complete remission, about a third, to increase to about a half. Counseling was a primary intervention here. About 50% of patients in the integrated program received appropriate counseling versus 27% in the usual care. And you see a 5-point scale measure of satisfaction was also modestly higher, but highly statistically significant given the large number of patients studied. When you put it all together, there weren't enough studies reporting remission and response to have a summary of that, but the standardized mean difference was similar to what we saw in the depression studies. There were fewer studies, so our overall assessment was that there was moderate certainty of a small net benefit. It was highly statistically significant, consistent across the studies, but there were fewer studies with a wider confidence interval than for depression. And again, this effect size is on the small to moderate size. With that, we'll turn to other medical conditions, and this is specifically looking at patients with both diabetes and, say, depression, where the care management program was actually looking at both. So this is not just looking at patients who are in the IMPACT trial who also had diabetes and seeing did their diabetes improve. These were studies where the care manager was also actively working on diabetes interventions, medication adherence with diabetes, again, following up, getting tests and adjusting therapy based on inadequate response to therapy. So the care managers were actively involved with diabetes care in addition to depression care. You saw similar magnitude improvement in depression scores, and the hemoglobin A1C change. Hemoglobin A1C is sort of the standard intermediate marker for depression for diabetes outcomes, and the decrease in A1C. The extra decrease seen with the care manager was about 0.33%. To give some perspective, the addition of a new drug for diabetes usually drops the A1C by about 1%. So this is about 1/3 of the effect of typically adding an additional medication to the medical regimen for somebody with diabetes. So here there were fewer studies, particularly for the A1C. This was of borderline statistical significance. You see the confidence interval goes right to 0, so the p-value is right around 0.05. For other medical conditions, at this point, I would say there's low certainty of a small net benefit among patients with depression and diabetes. The most widely cited study in this area was by Wayne Caton, who's part of the group. He just actually passed away last month, but part of the group up in Washington State that's done a lot of these trials and ran the IMPACT study. In that study, they looked at other outcomes like blood pressure and cholesterol. Those also improved significantly in that study, but that's only one of the 7 studies, so that was one of the more powerful studies coming out looking at that condition. So other medical conditions, really, there weren't many enough studies to say anything significant in the primary care clinic. The one area that was studied quite a bit was acute cardiovascular illness in the hospital, but those interventions were not focused on integration into primary care. Quality of life outcomes that are usually broken up into a number of different subscales. The two that were consistently reported across a number of studies were the mental health quality of life. This incorporates questions about vitality, about social functioning, getting out and interacting with friends and family, asking about whether their anxiety or depression limits what they can do over the 4 weeks prior to the administration of the questionnaire, whether they felt peaceful and calm, things like that. So those are the kind of questions that go into an assessment of the mental health quality of life using a number of different instruments. And here, over time, there were highly significant improvements in those with that standardized mean difference ranging from 0.2 to 0.26 over the first 2 years. They diminished after that, again, probably reflecting the natural history of depression and anxiety, that they tend to get better at wax and wane, and so differences between intervention and usual care groups got smaller over time, though still favored the collaborative care management programs. In terms of physical health, here the quality of life, asking about their general health, whether it's excellent, good, very good, and so on, about pain, about whether their physical health limits what they're doing, what they accomplish, their ability to work or perform usual activities around the house. Here, the standardized mean difference was smaller, 0.10. It was statistically significant and remained so over 1 to 2 years. It actually took a little time. It actually grew over time. You didn't see a big difference in the first year, but you saw it in the second year. So in summary, for the quality of life outcomes, there's high certainty of a small benefit for mental health, not surprising given what we saw with the depression and anxiety outcomes, but much lower certainty of a smaller benefit in the physical health quality of life domain. Finally, patient satisfaction. There are 34 studies that reported, of the studies that reported patient satisfaction, 30 out of 34 reported higher satisfaction with integrated care, and 2/3 of them were statistically significant. When you pooled them, those that used a continuous measure, the standardized mean difference again was 0.3, so small to moderate impact, and was highly statistically significant. So again, our overall assessment was that there was high certainty of a small to moderately greater satisfaction for patients in the integrated care program compared to usual care. I'm putting this all together, given the many different outcomes. The summary is that there's high certainty, I think, of improvements in depression and quality of life, as well as patient satisfaction with the collaborative care model compared to usual care. There's low to moderate certainty of improvements in anxiety and in diabetes, mostly because of the smaller number of studies. And the magnitude of the net benefit was small to moderate for all of the outcomes, though most people would say clinically significant for depression and anxiety, particularly for depression. Remember, the remission in the IMPACT study went from 8% in the usual care up to 25% in the IMPACT program, so a fairly large absolute benefit in terms of remission and in response. And then I wanted to highlight there was limited data beyond the collaborative care model. I'll talk about this in the public comments as well. So one of the major comments we received from experts in the field was that the literature really represents the collaborative care model with very little evidence on other forms of integration, and we completely agree. Essentially all of the studies we investigated use some form of the collaborative care model, and really there's very little in the literature, particularly in randomized randomized trials looking at co-location or other systems of integration. So we agreed with that. There was also some concern that we were underselling the magnitude of the improvements with a collaborative care model. I've tried to present the numbers for you so everyone can discuss that and make that judgment, hopefully as a group today. And then we received some comments about the fact that we didn't include the literature on the patient-centered medical home. This is a relatively new movement that includes very often behavioral health integration as part of it. But it's very difficult to tease out the impact of behavioral health integration on the overall outcomes that have been reported. And there's not a lot of data in the literature. Most of it is observational from demonstration projects. So we look forward to richer analysis of the experiences of the patient-centered medical home, but we did not include that in our review of the literature. And with that, I will turn it over to Dr. Ohlendorf to talk more about the care value and health systems value analysis. Thank you. Do you want questions?
And we can just remind everyone that both Dan and Jeff will be available with the panel and our roundtable experts for additional questions and clarification to extend what they've reported here.
Or I could take a few questions now if people want. Well, it looks like there are. Dan, you could. All right. Dr. Elliott?
Jeff, methodologically, it seems like the impact trial was the strongest and most recent. Just a couple of questions. I gather patients were assigned randomly to usual care versus collaborative care.
So the impact trial is actually sort of at least the father, if not the grandfather, of many of these studies. So it was published in 2002. So it was actually performed almost 15 years ago.
Okay, so
it's
so
been
recent.
around for a while.
Okay.
They actually paired similar types of. I think I'm remembering properly. Many of these studies, rather than randomizing at the patient level, randomized at the provider level or at the clinic level. And I'm pretty sure the impact study randomized at the clinic level, which helps to avoid. It was all right. Patient level, okay. So there are concerns. So this was it was randomized at the patient level. Thank you for correcting me. I was there are concerns, and I highlighted in the written report that some of these randomized at either the provider or the clinic level to avoid so-called contamination, where providers might learn something from the intervention and actually some of that benefit would spill over to the patients in the usual care arm, in which case you would expect that the differences would be smaller. So that would argue that if anything, the benefits are conservatively represented in this trial.
Just two more quick questions about that study. What exactly was usual care? Usual care
depended on the clinic, and actually most people would say this was enhanced care.
Was it
because
no care, or was it care?
So most behavioral health therapy is delivered by primary care physicians, and so there's certainly. I mean, you saw in the numbers that a large number of patients were on medication in the usual care arm. So the primary care providers are identifying and treating depression. In this case, even in the usual care arm, there was systematic identification of patients with depression, so there were probably more patients identified and treated than perhaps would have happened outside of the study.
And last question. If you used a survey instrument to identify patients with depression in this study, could you tell us a little bit about this? Is this incapacitating depression? Is this the worried well who feel a little sad from time to time? I mean, the magnitude of the depression, was there some sense of how depressed these people were and how much it interfered with their function?
So I don't remember that level of detail, so I may let the experts in the room. There is somebody from the University of Washington that ran this trial who is one of our experts who will both give public comment and be available for discussion later. I don't know whether we want to let him. All right, well, I will let him talk more about that later. no matter what, we have some patients who I think psychiatrists would consider to have moderate to severe depression who report very little in the way of symptoms on these symptom checklists. Other patients who have a mild to moderate depression who report very, very significant depression. So there are some issues with that across the board, but these are very, very standard instruments, though, that are used in depression studies.
Other questions for Dr. Tice? Thank you.
Alex.
Oh, Alex. Sorry.
To turn my back. From my read of the evidence that was sent to us in advance, the PIC trial and the Quest trial for depression, at least the way I read it, seemed distinct from the collaborative care model. But now, are those included in the collaborative care model, or should we
in
read
fact,
those
the PIC trial was sort of one of the was more the grandfather. I think many elements from that trial informed the IMPACT trial. So,
okay.
I mean, yeah.
So we should consider those in the same grouping. Okay, thank you.
But it's difficult. Each implementation, in part, depending on resources, choices of investigators, local systems, each study, its approach to the collaborative care model is different, and that's one of the challenges, is to tease out what the most important elements of these interventions are in terms of improving outcomes, and I think that's one of the things we want to bring out in the discussion throughout the day today. Dr. Bauer?
Hi, Jeff. That was beautiful. So I just want to get back to this issue about the fact that everybody knew what the intervention was. And did that include the providers, too? That included the primary care providers in the IMPACT trial I'm referring to now?
I believe so, yes.
Okay. And you can defer, if you'd like, to the expert who apparently was involved with the trial. But I'm interested in knowing if there was, since all the outcomes that you talked about were subjective, if they actually did record what might be considered more objective outcomes, including days of hospitalization or, for instance, days of work lost. And then the other sort of related question was there any evidence of dose response? I mean, were we able to say that people that got more of the intervention actually improved to a greater degree than those who got less of an intervention? Just to try to get this issue about whether it was actually intervention or the fact that they thought that they were being studied.
So in terms of harder outcomes, what I'm aware of is there were, in a subset of the clinics, they did look over time at costs, including hospitalizations and so on. By 4 years out, there was actually a reduction in hospitalizations, emergency room visits, and medication costs overall in patients in the intervention arm. I think Dr. Ohlendorf is going to talk more about the economic analyses. So it's complicated. There was certainly an increase in costs initially, and there's some controversy about whether all the startup costs and so on were appropriately included in the analyses. I'll bow to the expert. There are so many analyses on this. I know they did look at diabetes outcomes and did not see a change in A1C. They looked at cardiovascular outcomes and saw no benefit in patients who had pre-existing cardiovascular disease but had a 50% reduction in first events in patients without cardiovascular disease, but that was at only 2 of the 18 clinics, so it's sort of subset analysis. It's hard to sort through all that, and it's not nearly as rigorous as the primary trial. We may need to...
Yes, Christine. Sorry.
Dr. Stein.
Michael. No,
I have
Christine.
two questions. One of them is, so there was data on specific diseases such as diabetes. Was there any kind of total cost of care data in these trials? So
I'm going to defer to Dr. Ohlendorf on that, but there are actually a number of systematic reviews of costs. Almost all of these trials, because implementation and cost is such an important issue here, most did some form of economic analysis and reported them, and Dr. Ohlendorf will summarize that for us.
And then my second question is really one of clarification. As I understand it, there was a systematic identification of patients there was a care manager, and then there was also some kind of monitoring or protocolized care model. But that doesn't mean that usual care or even in the intervention that all of these patients actually saw a behavioral health specialist. Could have been delivered by primary care, could have been delivered by behavioral health. I guess where I'm trying to go with this is, what actually is the key element? Is it the case manager? Is it the protocol? So I just want to throw that out there early on is what's the secret sauce?
Great. An important thing for discussion. All right. Dr. Steinberg?
My question goes to the qualitative evaluation of the trials where you go small or moderate. Is that internal to the trials themselves, or is that an implication from your own analysis? How do we quantify that? What does that mean?
The small net benefit or moderate net benefit?
Moderate.
Yeah, no, I based it. This is totally my judgment. So, again, I wanted to highlight that. I think that's an important thing for discussion here. So much of the data was summarized using these standardized mean differences, and using those metrics, the magnitude of the benefit in general was in the small to moderate range, what's considered small to moderate. But I think with the limited data on remission and response rates, other people may judge this as a substantial benefit, and I think that's an important thing for us to discuss. It's again, there are concerns, as Dr. Bauer brought up, that some of this we know from other literature that just having somebody call you and talk to you makes you feel more satisfied with your care. It may really not be impacting outcomes that much. It may just be impacting the way patients respond to questionnaires over time if they have many touches. So I think that's one of the controversies that Dr. Bauer was trying to raise in the discussion here. All right. And I think I've been told we should hold the rest of the questions until Dr. Ohlendorf, and then we can continue the discussion through the day. Thanks for your attention.
Thanks.
Okay, dollars and cents. Oh, wait, that's backwards. Sorry. So I, too, have no conflicts of interest. So as we introduced to you the last meeting, we're going to talk about our economic analysis in terms of two major components. One being care value, and the way that's been described to you in the past is the comparison of the cost and the potential cost effectiveness, as well as other contextual measures when comparing two or more different types of interventions. And we'll also look at things from the perspective of health system value. So what is the budgetary and other impact on the entire health system of introducing a new intervention? So for this particular topic, for our care value analysis, we opted against trying to develop our own model of the economic and clinical outcomes associated with behavioral health integration because of the huge variability in the settings in which this type of integration is done, how integration is implemented, and what intensity of integration occurs. So we felt that if we were to create any model, it would immediately not be generalizable to many other settings. So instead, what we did was we focused on a summarization of what is also a relatively rich literature-based evidence base on the costs and the cost effectiveness, as well as other economic impacts of efforts at integration. And then for health system value, there's a section of the report which we won't delve into in great detail today, but it does identify some publicly available resources for organizations that can aid them in estimating the costs of planning, implementation, as well as the quote-unquote steady state ongoing costs of integration. And we did do kind of a relatively straightforward model looking at what those costs might look like in a large accountable care organization, using some evidence from the literature as well as some other assumptions that we'll go through to try to give a flavor for what that impact looks like, both from the perspective of that large ACO as well as from the perspective of a payer. So my split between collaborative care approaches in RCTs that looked at economic outcomes and non-collaborative care approaches is not quite as clean as the split that Jeff looked at, but it comes very close. So we looked at 4 recent high-quality systematic reviews that focused on economic outcomes from these randomized controlled trials, identified 18 randomized controlled trials that tracked utilization and cost outcomes. And of those 18, 15 applied some sort of collaborative care approach. So 15 of the 18 are focused on collaborative care. I'm going to talk about the 3 that were not collaborative care first. I don't have a slide on this for one very simple reason. None of them were effective. So there was no superiority in clinical outcome between the intervention group and the usual care group. 2 of these trials focused on educational interventions alone. So I think in your table of key tables and figures, or your document of key tables and figures, Figure 7 is described as a permutation matrix. And there are 2 studies identified with educational interventions that increased costs but were not any more effective than usual care. The 3rd study was a pharmacist-led intervention in the Netherlands, which focused on optimizing medication management in patients. And not only were the results not superior for the intervention, there was also significant study dropout. I think 40% of the sample had dropped out of the study by 6 months of follow-up. So again, I got there a little bit of a different way than Jeff did, but we are going to be talking about collaborative care in terms of what is available from the evidence in the literature. So across those available RCTs, there was consistency. Again, Jeff's already described the clinical benefits associated with collaborative care, but the implementation of collaborative care increased costs over the short term. So these studies primarily followed patients between 6 months and 2 years. There were cost offsets identified, so the studies typically were very clear in identifying particular components of cost, whether these be emergency care, other outpatient and office services, inpatient care, medication, etc. The offsets that were most often observed in the studies, in the short-term follow-up of the studies, were focused on specialty mental health. So presumably in these collaborative care approaches, a lot of the services patients required were delivered by primary care with support from the care coordinator or care manager, and the patient did not use as many specialty mental health services because of that. In the subset of studies with patients who were co-diagnosed with depression and diabetes, there were other offsets associated with reduced inpatient and emergency department care observed. And as Jeff alluded to during the Q&A, there have been longer-term studies from some of these trials that have demonstrated the potential for cost neutrality, so those increased costs of the initial intervention being completely offset, or overall cost savings over time, but they're very limited in the number of these studies as well, and also have some quality concerns as well. Some of those quality concerns include long-term follow-up for a short-term intervention, so interventions delivered over a 6-month to a 1-year time frame. The follow-up or 4 or 5 years is after the intervention is stopped, so there's the potential for confounding in the intervened group from other aspects of care beyond the intervention itself. Some of these studies report patient attrition over long-term follow-up. That's natural with any long-term follow-up study, but there's not enough information to know whether that attrition was systematic, whether it was more frequent in the intervention group versus the control group, for example. And then a third potential quality concern is that oftentimes, and this is a reality when looking at utilization and cost data, not all sites report those data, and not all of them report them with sufficient detail. So oftentimes, a convenient sample is what was available to the researchers to do the work. So with that first message about increased costs generally over the short term, there have been studies that have also looked at the potential cost effectiveness of behavioral health integration, and there has been some consistency there in that these have met generally accepted and published thresholds for what represents a cost-effective intervention. So that's typically somewhere between $50,000 and $100,000 per quality-adjusted life year gained. And the studies that have reported, conducted these sorts of analyses and reported these outcomes, again, based on the trial results, have produced those results in a range of $15,000 to $80,000 per quality-adjusted life year gained. So this table is also in your key tables and figures, I believe, but this is just basically describing the range in the incremental cost associated with integrated care. Everything's presented in 2014 dollars. And so there is quite a high degree of variability. Again, this is supportive of our, I think, of our decision not to do our own model, because the costs of implementing and delivering integrated care do differ very much by the type of setting in which it's delivered. So just to illustrate that range here. So in addition to the RCT-based studies, there have been several observational studies published as well that have shown some potential for cost savings associated with BHI over anywhere between 2 and 5 years of follow-up. But there tend to be some major quality concerns with these observational studies, whether there is selection bias associated with the selection of sites and providers, and in some cases imbalances between the intervention and control groups. So we're putting more stock in the findings from the RCT-based evaluations. But a challenge with those RCT evaluations is that there may be some understatement of the costs of BHI itself. Oftentimes, the costs are calculated post-randomization. So patients have already been screened and identified, which means the costs of screening are not included in the cost of delivering the intervention. And from an institutional standpoint, you would want to include, ideally want to include the costs of actually planning and implementing that intervention as well. And those tend not to be either included or not reported in sufficient detail in these studies. So again, there's more detail in the report on how institutions might be able to make use of some of these publicly available resources, and resources are available from organizations including the Prescription for Health campaign, as well as Advancing Care Together, 2 Colorado-based programs, and I believe we have some representation from those programs on our roundtable later. SAMHSA also has produced some resources for use as well, and there is one publication that also comes from Prescription for Health that provides some details. And really the 3 major categories to consider are those costs of planning, selecting the right screening tool, understanding what kind of training to implement, putting a hiring plan in place, et cetera. Startup costs, the cost of training itself, any sort of administration associated with it, if there are investments in equipment and or space, those kinds of things. And then the steady state costs. What are the incremental costs associated with delivering the integrated approach in practice? So let's turn to our budget impact analysis. Again, we assumed we would be looking at a large California ACO, 200,000 lives. We focused on a primarily employed, privately insured population. So the prevalence of major depression is about 3% in those kinds of individuals. Based on the Prescription for Health publication, which had a mean or median estimate of startup time of about 4 months, we assumed that as well. And then for this 1-year snapshot, we assumed the remaining 8 months of the year would be associated with kind of the moving into the steady state, delivering the intervention. Based on staffing ratios produced by the University of Washington Ames Center, we assumed for this 200,000 member population that we would be require hiring 40 nurse care managers and 10 psychiatrist consultants. We assumed a modification in the job role for medical assistants to conduct the screening in primary care, but no additional hires there. We know from the publication from Prescription for Health that some of the variability in implementation costs are associated with whether there needs to be major systems and IT change. We assumed that this ACO already had an interoperable electronic health record that would require minor modifications and not any sort of major IT investment. We did assume some additional capital expenditures for the new hires for workspace, and this is probably an overly optimistic assumption, but we assume that all patients in this 200,000 member panel would actually see the doctor during this 8-month period and be screened. So a simplifying assumption. So in terms of the startup expenses, and again, some of the measures were updated to 2014 dollars, but were focused on practices that had characteristics in the published literature that were similar to the type of ACO we were talking about. But overall, we're looking at startup expenses of about $40,000 for this ACO. And really across all expenses, because there is primarily the major expense here is staff hiring and staff time, about 70% of the costs are variable, about 30% are fixed. So $40,000 for startup expenses on a per member per month basis from the perspective of the ACO, that's about 2 cents. And in terms of steady state expenses, which is really where the investment comes into play, costs of screening, about $300,000, and the cost of delivering the intervention through the use of the new hires and other staff, as well as overhead associated with that intervention, really represent the bulk of costs here. So on an overall basis, for this 200,000 member ACO, we're estimating that total expenses in that first year would be about $7 million, or $2.84 on a PMPM basis. Now, I have to say that based on the discussions of the collaborative care approach, we assumed something that was probably at the higher level of intensity. So these care managers were on site, and they were connected to psychiatrist consultants who were dedicated to this integrated approach. And so other forms of collaborative care might involve less investment. So we were probably on the more intense side. So to summarize then, startup and screening costs were relatively modest in our model. Direct staff and overhead represent the major drivers of cost, and that incremental expense is $2.84. From the perspective of the ACO, and we've received a quote of about $26 PMPM for the cost of delivering primary care in an ACO environment. So that represents about an 11% increase in that cost. But again, we introduced this notion in our meeting in December. The idea from the plan perspective is to think about this from what we're now terming a value-based pricing benchmark. So that 0.5 to 1% PMPM range representing the range in which most payers can absorb the introduction of a new intervention without needing to make special arrangements for financing or limitations on population receiving the treatment. So from the perspective of Medi-Cal, with its most recent publication of PMPM of $552, that increase is about 0.5%. We also did a couple of sensitivity analyses in the report. One of these involves speculation that there might be an offset in total health care costs associated with this intervention over time. And if we assumed a 5% offset in annual costs of about $8,000 for a patient with depression, the investment would decrease to 7% from the ACO perspective and 0.3% from the payer perspective. So to summarize, from the care value perspective, the literature is telling us that there is incremental clinical benefit over usual care, as Jeff described, but at an increased cost over the short term. However, these interventions, again, collaborative care interventions, fall within generally acceptable thresholds for cost effectiveness. From the health system value, this is a little more difficult because, again, realities may differ for any one setting. because the economic studies have shown that BHI interventions increase costs, at least in the short term, and there is limited evidence on long-term cost offsets, there's a challenge in trying to understand how the health system value might play out in any one setting. But from the perspective of the investment itself, startup and ongoing costs appear to represent a significant investment from the perspective of an ACO, but a relatively modest change from the perspective of the public payer. So there were limited comments on the model itself in terms of public comment received. There was some discussion about the idea of targeting these sorts of interventions to populations who might be more severely incapacitated by behavioral health issues. These are also likely to be the populations to show a greater potential for cost offset. And with that, I'll take any questions.
And in terms of questions, I have one, and then I'm going to ask the panel for questions. But I have a question about the core value, and we've taken as sort of a given that if the incremental cost of an intervention gives a QALY between $75,000 and $100,000, that it has value. And your numbers are well under that, suggesting that using those criteria there is value. I have a little trouble finding that the incremental cost for a year, a quality year of life gained, I mean, I understand that in something like cancer or heart disease where there is actually a longevity issue and so on. Can you help us understand using the QALY analysis in this area?
Sure. So yes, what we're not talking about is a survival component in terms of the QALY benefit. What we're talking about is an increase in the number of days over a given period of time free from depression. So the utility really comes from having better results in terms of depression-free days, and those have been tied in really many studies to gains in utility and quality of life associated with a reduced burden of depression.
Thank you.
Yeah,
Dr. Rentschler.
Dan, I apologize for talking to you with my back to you, but having apologized, I'm going to do it anyway. Two questions. One, sure. The budget impact analysis summary, is this correct? PMPM for a commercial, $26, for Medi-Cal, $552?
So $26 is from the perspective of the practice itself. So the expenditures for a large integrated practice have been quoted at about $26 per member per month. The $552 is the overall Medicaid, Medi-Cal spend for all services.
Okay, so the 26 isn't including inpatient, stuff like that?
No, it does not. It's basically primary care's share of that 552.
Okay, so these aren't exactly comparable numbers. It's just from a
right. What we tried to do is contrast the perspectives of
your budget impact analysis assumptions. Your new hires for the care managers were all RNs. This obviously has significant cost implications, not to mention finding that number. Is it possible that lower-level providers could legally, because the state has parameters as to what, for example, a refill, I think, has to come through an RN. Mm-hmm. Could somebody legally and effectively do this job at a lower level of training?
I think that lower-level roles have been used to fill the care manager, care coordinator position. We picked RNs and nurse practitioners because simply in the studies that we looked at, that was the most frequent role used for the care manager, but it doesn't have to be.
Okay, that's my point. Okay.
Jed, would you go ahead?
Thank you. Dan, would it be legitimate in your economic analysis to think whether the behavioral health intervention and consultant would unload and free up capacity in primary care who would otherwise be dealing with at least some of this, and thus count that as a positive cost benefit?
Yes. So some studies, in fact, those studies that have focused on planning and implementation have tried to quantify what freeing up primary care might involve in terms of cost savings, yes.
Doug?
Well, I'm not so sure about that, because if my numbers are right, with 40 RNs, that's 150 depressed patients per RN and 600 depressed people per psychiatrist that you mentioned.
Right.
So where did those numbers come from? Are those more or less sort of similar to what was in Impact, or?
So what we did was we looked at staffing ratios produced by the Ames Center at the University of Washington. So I think there are 3 levels of need of the population: low, medium, and high. We picked the staffing ratios associated with the low need population, and the caseloads per care manager were somewhere between 100 and 150.
But I assume you said that personnel costs were what drove this. I assume that's very sensitive to the number of RNs and psychiatrists that the system hires.
Yes, it would be.
Christine?
So I'm assuming your ACO population is predominantly a commercial population.
Yes.
And then we have the Medi-Cal population. What about the senior population, the Medicare population? Any analyses on that?
There certainly have been some studies that have focused on those populations. I believe the IMPACT trial was in late life depression. So if we had opted to, we could have taken that perspective as well.
Right, because the spend numbers are very different for that population. So if your cost to implement your program are the same, you're now looking at a much different baseline spend.
You're looking at a much more modest investment from the perspective of Medicare, because the Medicare spend per PMPM is much higher.
Exactly.
Yes.
I'd like to hear a little more about the offsets in terms of improved access and throughput for primary care as a result of implementing these models. You mentioned it just a moment ago, but I haven't seen much data on that.
I should have clarified. I think that the opportunity for trying to quantify improvements in efficiency are part of some of those resources for planning and implementation. That level of detail was not reported in the studies, though, the studies that actually tracked economic outcomes.
On?
Yes.
Okay. This might be more a question for Jeff. So you looked at the satisfaction of patients with the system itself, which was high. Did you also look at the satisfaction of patients seeing primary care docs who really were not using the system, for whom it actually didn't apply, and did that impact their view at all in terms of the quality of care?
I could answer, but I'd be wrong, so I'll let Jeff answer.
I don't think so. So really, the satisfaction questions were all about satisfaction with behavioral health care or depression care. So it was very specific to what was being studied. So it wasn't overall patient satisfaction with care, and certainly there was no assessment for folks who were not coming into care.
Okay, yes, Alex.
And this may end up being a question for Jed. When we're voting on the health system value, we've in the past emphasized that we wanted to take the perspective of Medi-Cal. Are we taking that same perspective today?
That has been our instruction in general, though I think we are educated by the perspective of commercial payers in the room, too.
Okay, Paul.
I think one other way that might help frame the per member per month is it would put into context of the current payments, the supplemental payments that, say, Medicare or private insurers pay, which I think does range from a few dollars to, I think Medicare is up to 20, and then we'll drop that to 15 for
integration.
Type of integration care and so you can imagine if you're thinking of a budget that I have for this type of work, I think, okay, can I add on this $2 to that budget?
Right. Yeah, so that the $26, actually the source for that was the Medicare Comprehensive Primary Care Initiative, which is talking about those bundled payments, the payment supplements that Dr. Heidenreich just mentioned. But it is clear from that initiative that there's an expectation of cost savings from some level of integration, so that supplemental payment will drop over time. But it is in that couple dollars of investment, PMPM is in that range, yes.
Corollary to that is, maybe you meant this, Paul, but the CCM codes that are newly available, the $49 for Medicare, for example, the $49 per month PMPM for enrolled patients, were you including that, which is brand new as of 2015?
So the budgetary impact analysis that we did assumed the perspective of the ACO itself. So it was their investment. We weren't thinking about payments. We were thinking about cost to the system, both from the ACO perspective and potentially the payer. So we're not incorporating revenue assumptions into our particular model.
So, staying on schedule, I want to thank Dr. Tyson, Dr. Ohlendorf for very nice presentations, and we have and next we have a section for public comment. We have two people who have requested to comment before the panel. The first of whom is John Fortney. Dr. Fortney is Associate Director for Research at the Ames Center from Seattle. Dr. Fortney.
Thank you. And I have to say, I just moved to Seattle last year, so I was not involved in the impact study, so I can't give you the nuances.
Thank you. Sir, you have 5 minutes.
Yes, okay. So, as you know, the field of integrated care is fraught with misinterpretations of the data and problems with the terminology, so I think your report helps us really move forward into understanding what the data is telling us and not telling us. Collaborative care, which is developed by Wayne Caton at the University of Washington, is a type of integrated care. There are other integrated care models, but collaborative care is a specific type of model. And we defined it as such. It's a type of integrated care that operationalizes the principles of the chronic care model. It's used to improve access to evidence-based mental health treatments. It's measurement-based with screening and monitoring of patient outcomes to assess response. It's team-based, led by a primary care provider with support from a care manager and consultation from a psychiatrist who makes treatment recommendations for patients who aren't improving. It's population-based, uses a registry to monitor treatment engagement. It's patient-centered with proactive outreach to educate, activate patients, promote their self-management and adherence, and coordinate services. As Jeff said, there's 80 randomized controlled trials. And a common misinterpretation of these data is that because collaborative care is effective, all integrated care is effective. And that is not the secret sauce. Typically what's done is people hire a therapist, co-locate them in the primary care setting. When reading this report, it's easy to make the opposite misinterpretation of the data, which is because there's no evidence for integrated care, that means collaborative care is not effective. And that's more problematic, in my opinion, because it puts barriers up in terms of implementing collaborative care. So there's a specific statement in the report that says lack of correlation between level of integration and treatment response. And you can mistakenly misinterpret that as collaborative care is not being effective. But as the AHRQ review concludes that collaborative care is associated with significant improvements in treatment response remission across various levels of integration. In other words, collaborative care works regardless of how integrated the providers are, whether they're co-located, et cetera. And the report, I think, kind of makes it easy to do this misinterpretation because it uses the framework developed by Sampson and HRSA, which combines terms of collaboration and integration together in a single index in a kind of a linear way. So it's easy to interpret things like integration, it doesn't improve outcomes, and to assume that that means collaborative care doesn't improve outcomes. So integration and collaboration are not the same thing. Collaboration is necessary to improve outcomes, and it works regardless of the level of integration. There's very little scientific evidence that integration in and of itself improves outcomes, but that shouldn't be used to conclude that collaboration doesn't work. Thank you.
Could we just could you just say in a very practical way, I'm a primary care doctor,
okay,
and I want to participate in collaborative care. What does this mean? You have a psychiatrist down the hall that you can call on. Can you tell us exactly what you mean by collaborative care?
Collaborative care is very flexible and adaptable in terms of the integration. So in Washington State, the university supports federally qualified health centers in the implementation of collaborative care. The primary care provider is there on site, and they typically hire a nurse or social worker to be a care manager. That care manager does a lot of telephone calls to patients to make sure they're taking their medications and that they're improving. When there's a problem, they discuss that patient with the psychiatrist. They usually meet once a week. Psychiatrist might review 60 patients during that time and is able to touch a lot of patients, much more so in an hour than they would see one patient in an hour. So it can work. You can have a psychiatrist on site, but typically the psychiatrist is not seeing the patient. They're talking to the care manager who's feeding them clinical information, and they're making a determination about what to do next. If they can't get enough information from the care manager, then they will do a site consult, which we often do by telemedicine.
Thank you.
Thank you.
A couple of questions. Gerald, Dr. Winslow.
Yeah, well, I'm just curious, in that Washington model, have you tried different levels of care providers, marriage and family therapists and others that might be lower cost to the system?
I moved from Arkansas. We often used LPNs, and they work fine. RNs work very well. There's a group in Philadelphia at the VA that essentially has a lot of things scripted out, and they use batch kind of non-clinicians to do some of the data collection. Therapists work very well, and they can be trained into also delivering brief evidence-based psychotherapies like behavioral activation or problem-solving therapy. It's very flexible in that regard. These encounters with patients by the care manager are designed to be fairly brief, 15, 20 minutes and for follow-up calls.
Well, one more question for Dr. Fortney. Yes, Doug.
Well, a quick question. So does that number of 150 depressed patients per case manager and 600 per psychiatrist, does that resonate with what your experiences in Washington? Does that sound about right?
Yeah, it's based on the work with the FQHCs. They've worked with 45,000 patients there. I know in my randomized controlled trials, when our nurse care manager has 150 patients, she's pretty grouchy, so that's about the maximum.
Okay, well, one more, Christine.
Yeah, can you give me a sense of what the length of time a patient is actively engaged in this program?
A lot of the trials have kept the patients in for a year, but essentially what you're trying to do to be as efficient as possible is optimize the medication or the psychotherapy until the patient responds and then remits, and once they're remitted, you discharge them. They might come back into your panel, your care manager panel, because they screen positive again next year or 5 years from now, but it's designed to be time limited until they respond to treatment. And if they don't respond to treatment after 12 months, then you do a facilitated referral.
All right, thank you very much. Our next speaker wishing to make public comment is Dr. Kenneth Wells. Dr. Wells is from UCLA and Rand. And Dr. Wells, please take the podium, and you have 3 minutes.
Okay, I have to speak quickly.
We'll give you 5.
Okay, I'll be quick. Just to place myself in the discussion, so I was the principal investigator of the PIC study, or the Partners in Care study, on the Scientific Advisory Board of the Impact Study, co-PI of the Youth Partners in Care study, and co-led the American Red Cross mental health relief efforts in New Orleans after Katrina, combining the impact and the PIC study and other studies. So that's this perspective from which I'm speaking. First, I just want to make a brief comment about the context for collaborative care or integrated care. Depression, anxiety disorders are often underdetected. When we talk about increased costs from implementing collaborative care, what we have to remember is half the time patients are missed entirely. And when they're found, only half of those, or 25% of the time, are they treated appropriately in primary care. So, and many studies have shown that. So the increased costs have to be put in that perspective from an ethics and equity perspective. Also, these disorders are among the major contributors to morbidity in the world. So we need to be thinking of their impact on functioning. And thirdly, there are major disparities, ethnic and racial disparities in access to appropriate care for these disorders, which from a Medicaid perspective is a very important thing to keep in mind. And most of the available, in fact, all of the available meta-analyses do not touch on most of these issues. But some of the studies have. So I'm going to just very quickly in 1 minute, and then I'm happy to answer more questions later on. So in relationship to disparities, the impact study found a similar benefit for minorities as for white populations. The PIC study found 4 to 5 times more outcome benefit for minorities as for whites. In fact, by the end of 5 years, there was an elimination of disparities for African Americans in their outcome and 2/3 reduction in disparities in outcomes for Latinos compared to whites relative to usual care. John Fortney's VA study found a very similar level of a greater reduction from collaborative care for African American especially and other minorities relative to whites. So for Medicaid, that's a very substantial thing. So if you think of, let's say it's even twice as much benefit for minorities, what is now a small to moderate effect size becomes a large effect size. So it's kind of like whose point of view are you taking in evaluating the effects of these interventions? Similarly, in relationship to impact on morbidity, 2 of these studies, the PIC study and the QUEST study, both looked at the effect of employment. And in the PIC study, we found over 2 years an improvement in employment equivalent to removing the national unemployment rate from the depressed population. That's not, even though that's 7 percentage points, that's not a small effect. So again, it depends on what are you viewing when you're commenting on a small effect. It's only 2 studies that have looked at that outcome. For adolescents, I'm going probably over time already.
All right, go ahead.
For adolescents, depression is the 3rd leading cause of death in the world from suicide. There are 2 studies that have looked at the effects of collaborative care on adolescents, which are not included in your review, much less studies of children for ADHD and externalizing disorders, which are not included. So those 2 studies, Laura Richardson's from Seattle and Joan Asarno's earlier study, for which I was the co-PI, found about equivalent benefits for adolescents over 6 to 18 months as for adults. So in other words, it looks like these are also interventions that are helpful for children, for adolescents. And then, of course, you're also talking about, they didn't look at whether suicide was reduced. They weren't large enough to have the power for that. But that's the concern with this age group. I also just want to make a general comment that public health trials know that small effects for large populations have very significant public health benefits. I have other comments I could make. One of them is on the effects of the design. So some of the comments have been, well, why do the studies have these different costs and different effects? It's because the studies are designed differently. So the impact study was individually randomized. It's like a clinical trial in that respect. You're delivering the intervention to a person. The PIC study, you're moving a whole practice forward. You're not saying, give this to this person, give this to this person. You're supporting the practice and change. So then you follow people. It's like we call it an encouragement design. For those kinds of studies, not everybody gets the treatment, right? It depends on what the practice decides to do. So you're going to have smaller effects, you're going to have lower costs, just because this is more like what really happens when you support a practice, and you don't say you have to give it to that person. So that's some of the variability and none of the meta-analyses comment on that point, the effect of the design in that respect on why there is variability. So I'm just pointing that out to the panel. For minor depression, which is also commented in the report, so there are 2 kinds of issues with minor depression. One is, do you treat it? And those studies show there's very little benefit from treating it. or do you use it as a marker and manage it with early intervention, prevention? And those are the kinds of approaches that the PIC study, the YPIC study used. We specifically looked at what happened with minor depression and found large effects, especially for employment. It's like if you, but it's not from treating it. It's from taking it as a flag to help route those people in their lives, like seeing early diabetes or something like that. So I just wanted to say that for a variety of reasons, you're kind of doing, the right conclusions for what you looked at, but in fact, it's a little bit out of context, especially in thinking of the costs. You have to do something, for these individuals. And then it's not really looking at the disparities. As a final note, and then I will sit down, so we've done the one study that had 10-year outcomes. And over those 10 years, we found for minorities that the effect of one shot at better care through collaborative care was equivalent to removing 6 to 12 deaths of a loved one over a decade in terms of the cumulative psychological impact from the mental health quality of life measure, calibrating that to what happens with the death of a loved one in a year, if you follow me. So if you add up that effect from all the waves that we had over 10 years, it was equivalent to removing the psychological impacts of 6 to 12 deaths of a loved one for ethnic minorities. Anyone who's lost someone knows that's a pretty substantial gain. So again, it's like, how are we viewing, what's the context, and are we really understanding what these illnesses represent? Thank you.
Dr. Wells, would you stay at the podium and answer questions? Do we have questions of Dr. Wells? Since you're here, I'd like to tap into your experience about the survey instruments.
Yeah.
We look at diagnostic techniques, imaging techniques, and how sensitive and specific, et cetera, et cetera. How good do you view the survey instruments in psychiatry, say for depression, as a means of identifying people as a new patient who might have this problem, or as a outcome from an intervention? And the other thing, I'd like to get a sense of, we all have ups and downs. I mean, the existential dilemmas and so on. But how good are they at identifying real functional impairment? I mean, those are the questions.
Okay. Well, so first of all, the vast majority of the studies of collaborative care have, although they use screening tests, limit the studies to people with disorder. The only one that doesn't are my studies, because I believe in a broader view of what's important to manage. So those are studies of people who have a diagnosable disorder using the same kind of diagnostic test, probably more rigorous than a psychiatrist would use in interviewing a patient. So the fact that it's self-report, that's what we do. I mean, we take the symptoms, we add them up. Does it meet criteria for a diagnosable disorder? So the vast majority of these studies that have been reviewed, that's the population that's being looked at. Our studies use the screening measure. We do the diagnosis, but we don't require that to enter into the trial. And that's why we know what happens to people with minor depression in those studies and have seen improvements for those populations. And, with depression, the information you have is either from asking about symptoms or asking collateral information of family members. And certainly for our adolescent studies, we also get corroborating data from family members as well. So it's very similar to what you would do, clinically. Right, and about 60% of them will have, a disorder, but those who don't have something else. They have anxiety, or, the other thing, perhaps it's relevant to note, since you're talking about Medicaid, is a trial that we recently published. Again, that's not here because it's a little out of your scope. Included primary care, but lots of other sectors of the community in what you might call a community health home. And there we found when you implement a collaborative care model across the whole community, we did use case managers and health workers and all kinds of task shifting to ministers and so forth. And we've published this and found improvements in mental health, physical health, reductions in homelessness, 50% reduction in hospitalization. So, again, from a Medicaid perspective, there are similar models. It's not just about primary care. That's your panel is about primary care. But as the ACA moves forward and so forth, and we're thinking of the models, community health homes are also, with FQHCs, very actively being considered. So there are some other relevant studies out there that are randomized trials that, anyway, are in the literature. Thank you.
Kim, you had a question.
Okay.
If you take your public health hat off for a minute and
Okay.
speak as a psychiatrist,
Yeah.
how do you feel about the scope of work changes that would need to happen if we were to make this cost effective?
Well, there are lots of, it's a great question. And there are, that's where a lot of emphasis is right now. So, for example, using social media or technology to increase the reach. Some of the Seattle work is focusing on, both telemedicine and social media. Some of our work has been doing that. I don't think we have the data from the new trials yet with all of those tools. But this is true in all of medicine, right? We're all struggling. With depression, depression really is kind of a population management issue because so much of it is undetected. And, and also outreach is needed because of the stigma, right? So I think it's a practice issue, but it's also a population management issue. I guess what might not be really clear, what I'm hearing from the questions people asking is kind of how does this really work? So you go into a practice, you give some training to the primary care doctors and, managing medication. You want to make sure they understand what the therapist is doing and who the therapists are. In the impact model, you're training the nurse care manager to also be a short-term therapist, right? So you don't necessarily have the additional cost of the psychologist, let's say, unless it gets beyond the brief session that care manager is doing. In our model, we're giving them some, maybe even briefer, and then more, sending them to group therapy, which is, sort of cheaper. But a lot of this relies on activating the patient, the patient and their family to understand what this is, what are the coping strategies, how can you proactively do this, and how do you build that self-efficacy. So it's kind of a combination of getting the patient and the family on board, making sure the doctor can do their job, bringing the specialist in as they need it, and then having these intermediate care level to track, to screen, but also in some models to actually deliver evidence-based psychotherapy in that kind of friendly, near-term way.
Okay, thank you very much. Well, we're at that point where we will break for lunch and reconvene at 12:20. Sharp.